In this lecture, I'm going to talk about urine examination. This video is particularly aimed at the first and second year MBBS students who are going to their biochemistry and pathology exams respectively. When I was in MBBS, I just tried to memorize these urine examinations without not really understanding how renal physiology really works. So this is my attempt at teaching urine examination the way that I always wanted to be taught. So let's get right into it. So if I ask you this question, that is, which is the filter in our body, the answer is kidney. Now in the kidney, if I ask you another question, that what is the functional part of the kidney, I know every one of you will get it right, and that is the nephron. And you know that in the nephron has various parts. So the first thing, the thing which looks red like that, it's like a ribbon, and that ribbon is the tuft of capillaries, and it is called as the glomerulus. Now below the glomerulus, there is a cup-like structure, and this structure is called as the Bowman's capsule. And below the Bowman's capsule, we have a long slender thing which is called as the renal tubule. And there are different parts to this renal tubule, such as the proximal convoluted tubule, followed by the descending limb, followed by the loop of Finley, followed by the ascending limb, and then you also have distal convoluted tubule, and lastly you have the collecting duct. Now, let us try to focus on the real filter out of all these three. The filter, the filtration, etc. It happens at the glomerulus, and we'll try to see how this happens at the glomerulus. So I'll just zoom in on the glomerulus and we'll see how this works. So zooming into the glomerulus, we can see that the glomerulus is a tuft of capillary, and I have focused on one glomerular capillary. Now we all know whether it's a capillary, whether it's an artery, whether it's a vein, they're all lined by cells called as endothelial cells. Now the speciality about glomerular capillary endothelium is that the endothelium are spaced away from each other. So they have this big gaps between each other, and because of that they are called as fenestrated endothelium. Fenestrated just refers to there are more pores in the endothelium kind of, because the endothelium are much away from each other, and as a result it looks like there are holes in this blood vessel. So as a result, what happens? As there are holes, as there are more pores, it is easier for things to leak out of this blood vessel, and this is called as filtration. Now if I just stop this lecture here and ask you what organ has the opposite of this, that is, I'm asking you, if the endothelium are very tight to each other, where there are no pores, there are very small pores. So if you are thinking the answer is brain, you're absolutely right. There is something called as a blood-brain barrier. And the reason why you have blood-brain barrier in the brain is the endothelium are very close to each other. We call them the tight junctions between the endothelium. So they don't let anything come through. So if you really want to send a drug to the brain, you send them via a lipid soluble mechanism so that it bypasses the gap between the cells and it goes from the middle of the cells, etc. So right here, this is a good way to understand how renal physiology works. So number one is that I don't know if you have ever seen such a filter. There are rudimentary filters sometimes used in very rural areas, wherein you take a bucket and you put a piece of cloth and this acts as a filter. Now think about how it acts as a filter. So let's say inside the cloth, you know that there are a lot of pores. So these pores, for example, let's say there is a river water that you've collected and you're trying to pour this river water into this cloth, into this bucket. So let's say the river water contains a leaf, for example. Now the leaf is bigger than the pores. So will the leaf get filtered, yes or no? It doesn't get filtered, it stays back because the size of the leaf is bigger than the pore in the cloth. Now what about the water droplets? Now water droplets are just H2O, they're very small particles, they easily cross the filter. So eventually what we had was we got the water down and we got this leaves or dust, anything which just accumulated at the top, and we got water at the bottom. Now is this water safe? Not really, because there still could be bacteria, etc., which are also very small and they also get filtered to the bottom, and obviously this is not very safe to drink, but that is the best some places got. So this is a rudimentary filter, and if you understand this, you understand exactly how renal physiology works. So now here, once again, let's take the glomerular capillary and let's take the fenestrated endothelium. Now let's take a particle such as glucose, represented by the G here. So glucose is a small particle, as you can see. So what do you think? Will it fit in this pores, yes or no? The answer is definitely yes, because the size of the glucose is smaller than the pores, the gaps between the endothelium. So the glucose is easily filtered. And what about structures such as an RBC? So let's take an RBC and let's see the size of the RBC. The RBC is obviously much more bigger than the pore. So will the RBC come down? The RBC will not come down. The RBC are not filtered, and the RBC will just go away without getting filtered. Now, what is determining the filtration? What property of the molecule is determining its filtration? For example, in glucose, glucose got filtered because it was small. What about the RBC? RBC was big. That is why it didn't get filtered. So the size of the structures, the size of the substances plays a key role in understanding filtration. And this is called as the size barrier. That means if a structure is bigger than the pore, it will not get filtered. Whereas if the structures are smaller than the pore, there is a good chance that these get filtered. Now moving on, let's talk about one important molecule. It's a very interesting case, and this is the curious case of albumin. You know that albumin is a very abundant plasma protein. It's the most common plasma protein. And this albumin, as you can see, the size is actually not that bad. It can fit the pore. But do you think albumin is filtered? The albumin is not filtered. Now why? Even though the size is small, albumin is not filtered. And the reason for this is there are other things to the filter apart from the endothelium and the capillary, and we'll talk about these things and I'll tell you exactly why albumin is not filtered. So number one, let's take an example of this. This is the epithelium, and the epithelium in the glomerulus, it is a little different because you can see there's little extensions like things. So these are called as foot processes, and these cells, that's why this epithelium, because it looks like it has feet, it is called as the podocyte, right? So podocytes, poda for feet, you know that word pseudopoda we say, right? So pseudopoda refers to there are like little movement like feet like structures which are there on the cell. So these are called as podocytes. And also all the epithelium in your body will sit on something. So what do epithelium sit on? Is there a membrane that they sit on? So if you're thinking of basement membrane, you would be right. And there is a basement membrane in the glomerulus as well, which is lying just below the podocytes, and that is the glomerular basement membrane. So epithelium rests on the basement membrane, and on bottom of that you have this glomerular capillary. So there are capillary, GBM and podocyte, and all these three together make up the filter. Now the reason why albumin is not filtered is, think about what charge is albumin. Albumin is an protein, and these proteins are usually negatively charged. So there is also negatively charged substances on the glomerular basement membrane and also the epithelium. So all the structures are filled with negatively charged molecules. So as a result, what happens is when negative charge comes in contact with the negative charge, it is getting repelled. And that is the reason why albumin is not filtered despite the size being smaller than the fenestrated capillaries. So what do we call this? So initially I told you that glucose and RBC, that was called as a size barrier, whereas this barrier is called as the charge barrier because the charge of the albumin is preventing it from getting filtered. Now there are two barriers here. So one is the size barrier and one is the charge barrier. There are some diseases in your body wherein this size barrier or charge barrier or both are affected, and as a result they lead to abnormal results in the urine. So once again, in the tubule, in the glomerulus, you have different things which happen. So as we talked about earlier, that is, initially we have something called as filtration, which is some of the molecules, they move from the glomerulus into the Bowman's capsule into the tubule. And there are some things which move back into the blood, and this is called as reabsorption. And there is also few things which come from the arteriole into the tubule, and these are called as secretion. So there is filtration, which is getting molecules into the Bowman's capsule. There is reabsorption, which is taking away substances from the lumen of the tubule back into the blood, and there is secretion, which is taking things from the blood and putting it back into the lumen of the tubule. Now if I ask you, can you give me a formula of urine based on these three things? So the formula of urine would be filtration minus reabsorption plus secretion. So this is where the urine ends, right? So if the tubule ends, so at this point we have filtration minus reabsorption plus secretion, which is still remaining in the renal tubule, and that is the formula of urine, which is filtration minus reabsorption plus secretion. So that was the basic idea of renal physiology. Now let's try to talk about what are all the abnormal components that are getting tested in the exam, in urine examination. So one is glucose, one is ketone bodies, one is protein, and lastly, you have blood in urine. So before that, I'll ask you some questions. So let's see all these four abnormal components. Do they get filtered, reabsorbed, or secreted? So let's try to see what happens. So we do not worry about secretions. So none of these four, they undergo secretion. So we are away from that. So we'll try to use the analogy of size barrier and charge barrier and try to understand what happens to each of the subnormal components. So now let's talk about glucose, for example. Is glucose getting filtered? Previously we talked that glucose is a small molecule and small molecules get filtered. So glucose get filtered. But in normal people like you and me, do we see glucose in our urine? The answer is a resounding no. So does it get reabsorbed? Yes. So in the urine you don't see glucose, and the reason why you don't see glucose despite it getting filtered is it is reabsorbed back in the tubule. Now what about ketone bodies? Do we normally see ketone bodies? The answer is no, we normally don't see ketone bodies. I'll talk about more when we go to the ketone bodies. So normally we don't see ketone bodies, but if they are present, they will be easily filtered. And are they reabsorbed? They're not reabsorbed because we don't have much use to ketone bodies when compared to glucose, and glucose would be more primary. Your body would try to preserve glucose when compared to ketone bodies. So we don't have a mechanism to reabsorb ketone bodies because we normally don't have ketone bodies as such. Now protein, there are a lot of proteins in your body. There are some albumin, there are globulins, etc., etc. So I'll keep this discussion to albumin. So what do you think? Does albumin get filtered? It doesn't get filtered because as we talked about earlier, there is something called as a charge barrier. So the albumin is not getting filtered. Now what about reabsorption? Obviously it is not filtered, so there is no reabsorption as well. But for some reason, if there is a pathology in which albumin is getting filtered, it is not getting reabsorbed. So if albumin gets filtered, it just comes into the urine. Now what about blood? Once again, when I talk about blood, I'm referring to more about RBC, and RBCs are much bigger, so they don't get filtered. And obviously, since they are not getting filtered, body doesn't have any mechanism to get them reabsorbed. So this is the basic idea of what we need to know before we go into the topics itself. Before I talk about glucose, ketone bodies, proteins, and blood, let me also tell you that I know that there are some people, some students, who never attended a practical class, and they're not very comfortable doing these examinations because they don't really know what instrument to use and how to use, etc. So I'll just give you a little tip to be like a pro. So that is, there are few things on the table when you do the examination, and if you use these things correctly, people will think that you know what you're doing. So you have something called as a dropper, which is useful for transferring liquids, and then you have a measuring cylinder, which is very important for measuring the exact amount. So someone says 2 ml, 3 ml, you measure that in the measuring cylinder by taking the dropper and trying to put it into the measuring cylinder. And then you can also use the test tube, which is where ultimately you pour the reagent or the urine into. So what you do is, when you see the dropper, when you see the reagent or the urine, you collect that with the dropper and you put it in the measuring cylinder. And once you put it in the measuring cylinder and you exactly note whether it's 2 ml, whether it's 3 ml, depending on the test, and you put that back into the test tube. Now, after you put it into the test tube, you can take this test tube, and there are something called as a test tube holder, and you put it on the test tube holder and you're ready to go. No one would ever know that you have never attended a practical class. You will look like an absolute pro and you're ready to ace this exam. So don't worry about being stressed, etc., because you can really do very well in this exam despite never coming to the practical class. Another word of caution is that there are some tests which involve you to heat the test tube, such as Benedict's test that we use for glucose. And when you heat some of the solutions, sometimes they can boil and they can actually come out of the test tube. So when you are boiling with your test tube, please make sure that you are not directing this test tube to any of your friend's face, because this solution can fall off and it can burn your friend's face off. So don't do it, don't direct it unless you really hate this person. But please. Now in the exam, the examiners will like to ask some of the questions, and the main common questions that they ask is, they'll ask you all the causes of abnormal findings. For example, they'll ask you what are the causes of glucose in urine. They'll ask you what are the causes of ketone bodies in urine, what are the causes of proteins in urine, etc. They'll also want to know all the procedures of the test that you have done and their principles. So obviously when you do the test, you should know how to do the test, and you should also know how the test works, which is the principle, and why are we doing that specific test for detecting the subnormal component of urine. They'll also ask you what are false positives and false negatives. So for example, let's say I'm searching for glucose, But even in spite of absence of glucose, let's say some other molecule other than glucose is giving me a positive urine result for glucose, that is called as the false positive. So also you need to know that are there any other tests that you can use? For example, there is Benedict's test for urine examination. They would like to know, are there any other tests apart from Benedict's test that you can do for urine examination? So now let's talk about the chemical examination of urine. In this chapter, we'll be talking about everything else, that is glucose, ketone bodies, proteins and blood, and we'll talk about all the tests, etc., everything you need to know for the exam.
And I know the chemistry. I'm thinking maybe you and I could partner up.
Now, number one is glucose in urine. So normally what happens is, as I told you before, that glucose gets filtered. So at the glomerulus level, the glucose gets filtered. So it enters the tubule, it enters the Bowman's capsule and then the tubule. So glucose is filtered, but why don't we see glucose in the urine is glucose gets reabsorbed. Now how is glucose getting reabsorbed? You know that the tubules, they have an epithelium which is called as the tubular epithelium. Now at the proximal convoluted tubule, that is where the glucose gets reabsorbed, and the glucose is reabsorbed by transport proteins, and these transport proteins are like trucks which are there at the border of the cell and the lumen, and what they do is they carry this glucose which has just been filtered and they put it back into the epithelium, and from the epithelium they find their way back to the blood. Now do you know what are these proteins called? These proteins are called as SGLT, and this specific proteins in the kidney are called as SGLT2, and this SGLT stands for sodium glucose transporter. So these proteins, they also carry sodium with them, so they carry sodium and also glucose, and these are called as SGL2. So let's see, if I ask you a question, right? So glucose in urine. Can you name any important cause of glucose in urine? I know most of you are jumping out and you're saying the answer is diabetes mellitus. So if you're thinking right now it is diabetes mellitus, the answer is absolutely right, diabetes mellitus. So now in diabetes mellitus, you know that the main cause of diabetes mellitus is decreased activity of insulin. There are two types, type 1 and type 2. In type 1, the pancreas are not producing enough insulin, whereas in type 2, you have insulin resistance. So either type 1 or type 2, eventually there is decreased action of insulin, and that as a result will lead to diabetes mellitus. Now, is there any relationship between this insulin and glucose? We'll try to explore that relationship. Now let's take a blood vessel. Obviously blood vessel is red, so that is the pipe which is representing a blood vessel. Now in the blood vessel, let's imagine there are some glucose molecules. Now in our body, if I ask you what is the function of glucose, you would probably tell that the glucose is a source of energy. So glucose has to be inside the cell, and inside the cell it produces energy. So which is ATP, right? So it undergoes glycolysis, it then goes to the Krebs cycle, and eventually it produces ATP. But does glucose just enter the cell like that? The answer is no. If the glucose wants to enter the cell, it has to have a transporter molecule, and this transporter molecule is called as a GLUT. And do you know what GLUT stands for? It stands for glucose transporter. So simple as that. There are different types of GLUTs that you study in biochemistry, and these GLUTs are GLUT1, GLUT2, GLUT3, GLUT4, and one especially is seen in RBC and brain, whereas GLUT4 is seen in skeletal muscle and adipose tissue. Now GLUT4, obviously it is there all across your body because skeletal muscle and adipose tissue is there all across your body. So this GLUT4 is important because insulin is directly proportional to GLUT4. So when insulin is there, GLUT4 is there. If insulin is not there, GLUT4 is not there. So these glucose transporters, let's see what happens. Now let's take a person with diabetes mellitus, and in diabetes mellitus, I told you just now that there is no GLUT4. So what happens when there is no GLUT4 or low GLUT4 is that the glucose molecules don't have a channel to enter the cell. So what happens as a result? They can't enter the cell, so they start pooling in the blood, obviously because they can't enter the cell anymore, and that's the reason why people with diabetes mellitus will have hyperglycemia. Now before I told you that what is the function of glucose, the glucose has to go inside the cell to produce energy because it is being used by glycolysis and Krebs cycle, both of them which happen inside the cell. Now you tell me, in this person, will the person have high energy values or low energy values? So if you are thinking that this patient has low energy values, you would be right, because even though glucose is there in the blood, it is not there inside the cell. So inside the cell, if it is not there, it cannot produce ATP. So obviously the patient will have low energy and the body thinks you're actually starving. So the body will ask the patient to eat more. So that is the thing which happens in diabetes mellitus, especially in type 2, is that this type 2 diabetes mellitus people already have obesity, and because of that they get this insulin resistance, and because of this insulin resistance they have hyperglycemia, and this hyperglycemia will only decrease their energy, eventually asking the patient to eat more and more, and it gathers this very bad vicious cycle, and the patient will have a symptom called as polyphagia, because the patient feels weak all the time and he'll have this tendency to eat more. So that is what happens, and that is the relationship between insulin and glucose transporters and glucose. So when you don't have insulin properly, you will have hyperglycemia. Now, when you have hyperglycemia, now let's see what happens at the glomerulus level. So there is all this increased glucose in the now in the tubule. What happens is that in diabetes mellitus, there are a lot of glucose molecules will get filtered. Now here we can see that there are three trucks, but there are two glucose molecules which are left alone. And these glucose molecules will come into the urine, and this is called as glycosuria. And the reason why you have this glycosuria is that the overwhelming number of glucose molecules outweigh the number of SGLT2 receptors. So there are not enough trucks to carry all these glucose molecules back into the blood, so they don't get reabsorbed, and those things come into the urine, and this is called as glycosuria. So now also one more thing to remember is that glucose is osmotic. So the meaning of osmotic is it also likes to bind to water. So this glucose will bring in a lot of water into it, and it will hold a lot of water, preventing the reabsorption of water. And tell me what happens as a result. The patient will have polyuria, and the patient will be losing a lot of water in the urine, which is a classic symptom of diabetes mellitus, which is polyuria. Now, if you lose a lot of water in the urine, obviously you would be dehydrated and your body will ask you to drink more water, and this is called as polydipsia. So in diabetes mellitus, you have a triad of polyphagia, polyuria, and polydipsia. So if you hear these three words, that means that the patient that they're talking about is a patient who has diabetes mellitus. So let us talk about other causes of glycosuria apart from diabetes mellitus. So there are some endocrine causes such as Cushing syndrome. Now think about what happens in Cushing syndrome is that cortisol always causes gluconeogenesis. So there is glucose always, and that eventually leads to insulin resistance, and that is why you get diabetes mellitus. Same thing happens with acromegaly, in which also there is insulin resistance because growth hormone is insulin like, and that is why it eventually leads to insulin resistance. And there is one important thing that they may ask in the exam, and that is called as renal glycosuria. Now some people will like to ask you, what is renal glycosuria? So I'll just tell you briefly about what is glycosuria. Now I told you in normal people like you and me, whenever the glucose comes into the renal tubule, there are these receptors called as SGLT2, which are the sodium glucose transporters, and they are the ones which reabsorb the glucose back into the tubular epithelium, and from there it goes back into the blood. But there are some people who have decreased SGLT2. So think about what happens as a result. So if you have decreased SGLT2, the glucose molecules cannot be reabsorbed anymore, and despite of having less glucose molecules filtered, they can actually come into the blood. A very good example of this would be a syndrome called as Fanconi syndrome when there is dysfunction of PCT. So in these people who have Fanconi syndrome, the PCT is not working, which is the proximal convoluted tubule. It has a lot of functions, not only glucose, it also reabsorbs amino acids, etc. And all these things show up in the urine, and this is called as Fanconi syndrome. So what are the tests for glycosuria? So you all know there is a very famous test called as the Benedict's test, and there is also one more test which is called as reagent strip method. Now one little suggestion is that reagent strip method can be used for every other abnormal component in the urine. So whenever they ask you, can you name me any other things, you can always say, for every test you can say reagent strip method. So we'll talk about Benedict's test first, and I'll briefly tell you about reagent strip just in a while. So let's try to see how we can use Benedict's test. So in Benedict's test, first what we do is we take 5 ml of Benedict's reagent. So now when I say 5 ml, you should remember that you should use a dropper, and you should take 5 ml of Benedict's reagent, put it in the measuring cylinder, measure it, and then put it into the test tube. So you know what does Benedict's reagent contain? It contains something called as copper sulfate. So what we have is we take this very beautiful blue looking crystals and we put it into the water, and eventually we get something called as the Benedict's reagent, which is an aqueous solution of copper sulfate crystals. So now we take this Benedict's solution and we add 5 ml of Benedict's reagent and we add 0.5 ml of urine. Now it is very important to remember that there is 5 ml of Benedict's and 0.5 ml, nothing more and nothing less. I'll tell you just in a while why, but that's important to remember. And what you do is you start heating it until it boils. So here I've just sped up my video, and as you are seeing, initially the blue has become a little green, and now the green is becoming a little yellow, and then it eventually becomes a little orange, and eventually it becomes red. So with the last color which comes as brick red precipitate, and here as you can see on the right side there is a very good brick red precipitate that we see at the end of the Benedict's test. Now most of these urine samples in our hospitals for the exams are prepared by just adding some sugars to the distilled water. So that is why most of the urines will give you a brick red precipitate, and I'll tell you why this color change was happening. Why did green become yellow and how did eventually it become orange and eventually it became red. So this is called as brick red precipitate, and if you see this brick red precipitate, that means there is glucose in this test. So now let's talk about the principle of Benedict's test. So number one is the copper sulfate, obviously, and then in presence of glucose is converted to this product called as cuprous oxide. Now we need to talk about some chemistry here, so just stay with me here for a while. We'll talk about what happens. So now you tell me what happened to the valency of copper. I know some people are already angry at me at talking about valency, but let's make it very easy and very simple to understand. So now we'll take CuSO4 first, which is copper sulfate. You know what is the SO4 valency? You know that SO4 is -2. So obviously SO4, CO3, you remember from your high school and inter days that SO4 is 2-. So what should be the valency of Cu then? We have one Cu and we have SO4, so obviously Cu should be +2, and that is how it balances. That is CuSO4 and Cu is +2. So let's see what happens on the other side. So here, you know, once again, O oxygen is 2-, so O is 2-. So now you tell me what should happen on the copper side. So copper, there are two coppers, so two coppers together is 2+. So that's how it balances, 2+ + 2-. So what happened to one copper? Now Cu2 is 2+, so what is Cu? Cu is +1. So what happened? So from copper sulfate to cuprous oxide, 2+ became 1+. So now in terms of electron, you've heard of a product called as electron, right? So what is electron? Electron is negatively charged or positively charged? So it is negatively charged. So you tell me what happened to the copper. Did it gain an electron or did it lose the electron? So as I told you earlier, electron is a negatively charged. So if +2 is becoming +1, that means it has gained one negative charge because we are decreasing our positive as we go from 2+ to 1+. So eventually what happens is the copper has accepted an electron. So now copper is an electron acceptor, and that is why we call it a reduction agent. So it has undergone reduction. Now which has made this copper undergo reduction? And the answer for that is glucose, because glucose is the one which has donated its electron to the copper, and that is why we say that the glucose is oxidized, and glucose, that is why is called as a reducing agent, because it was successful in reducing the copper from 2+ to 1+. So that is why glucose is called as a reducing sugar, because it can donate an electron, thereby reducing other substances. So in the exam, this question is definitely coming, and that is, what are reducing sugars and what are non-reducing sugars? So I'll talk about reducing sugars first. So most of the sugars that you know, they're all reducing sugars such as glucose, maltose, fructose, galactose, lactose, ribose. So let's try to remember what are the non-reducing sugars. Now very important to remember is sucrose, which is the most common table sugar. It is actually a non-reducing sugar, and also glycogen, cellulose, etc. So there is one little caveat in chemistry, whereas this non-reducing sugars, they don't have a free aldehyde group, that is why they don't react, whereas the reducing sugars will have a free aldehyde group, and that is why they can donate an electron and they can reduce other substances, and that is why they're called as reducing sugars. So in the exam, if they ask you name one common non-reducing sugar, your answer should be right away sucrose. So now apart from these other sugars, other reducing sugars, there are also other substances which are very important, and this is definitely coming for the exam, and that is Are there any false positive for this Benedict solution? So I've marked it in yellow, and very important cause of this false positive Benedict's test is actually people using ascorbic acid, which is vitamin A. There are a lot of people who take vitamin C supplement, and when they take this vitamin C supplement, you know that vitamin C is a water soluble vitamin. So it comes off in the urine, and when it comes off in the urine and you do Benedict's test, it will also be positive for this vitamin C, because vitamin C can also act as an electron donor, and as a result you'll get a false positive Benedict's test. So apart from ascorbic acid, you have to know that uric acid, which is increased in conditions such as gout, and also salicylates, which are drugs such as aspirin, can also do the same thing, and that is why they can all yield a false positive Benedict's test. This question is definitely going to show up because they're going to definitely ask you why we only use 5 ml of Benedict solution and why we only use 0.5 ml of urine. Why not more? Why not less of either? It's very important that we add this exact values while we are doing Benedict solution. So let me explain you why we do only this amount. The reason why is Benedict's test is a semi-quantitative test. So there are two types of tests. We have quantitative tests and we have qualitative tests. And in quantitative tests, we also have fully quantitative and there is also semi-quantitative. Now the way these works is when you have a quantitative test, it will give you the exact number of or the value. The value is just one number, whereas in semi-quantitative test, the value is actually the range. Now I'll give you an example. In quantitative test, let's say there's an example of 129 units. So you did a test and the quantitative test has revealed that your value is 129 units. In the same test, if you do it with a semi-quantitative, it will not give you the exact number, but rather it will give you a range, for example, 100 to 150. So here our Benedict's test is a semi-quantitative test. And one more thing to note that the color changes with concentration of glucose. So when we do Benedict's test and we call it semi-quantitative, and this semi-quantitative refers to the different colors that you get with different concentrations of glucose. So let me explain you how. Now let's take our Benedict solution and let's see how it works with this Benedict solution. So first, when the solution is negative, you see it is blue, right? It doesn't change anything. But when the concentration of glucose is 0.5 to 1, it gives you a green color. But now if we increase it more, that is 1 to 1.5 grams per dl, it will give you an yellow color. And then if the concentration is 1.5 to 2 grams per dl, it will give you an orange color. Whereas if the concentration is greater than 2 grams per dl, it will give you the brick red precipitate that we got in the test that we have done. So now this also explains that whenever we started heating, the color started changing from blue, it went to green, it went to yellow, it went to orange, it went to red. Because as we heated, more and more glucose were donating electrons to the copper sulfate and it was eventually forming cuprous oxide. So the more cuprous oxide was formed, the more concentration, and eventually we got this brick red precipitate. Now let's imagine a patient who has a urine concentration of 0.5 to 1. So when we do Benedict's test properly, this patient is supposed to get a green color. Now let's say we didn't do this properly. So let's say instead of adding 0.5 ml of urine, we added 1 ml of urine. We doubled the amount of urine. So when we double the amount of urine, even the glucose amount is doubled. So instead of 0.5 to 1, this guy will get anywhere from 1 to 2 grams per dl. So instead of having a green color, now the test is showing that this person has orange color. So that's the reason why we add the exact values. Now think about the opposite. Let's say someone has 1.5 to 2 grams per dl. Let's say if we, instead of 5 ml of Benedict solution, we added 10 ml of Benedict solution. So now the concentration of glucose in relation to the Benedict's reagent has decreased. So instead of getting an orange color, now it will actually show green color because we have increased the Benedict solution. So the amount of glucose inside it would obviously be lesser than compared to when we use the proper 5 ml. So it is always very important, since it is a semi-quantitative test, the concentration of glucose is directly proportional to the Benedict solution. So if you add more urine or if you add more Benedict solution, the solution results, the test results can eventually alter. So that is why it is very important that we add only 5 ml of Benedict's reagent and 0.5 ml of urine. Once again, this is showing all the different colors that you can get, which is initially, if it is negative, it is blue, little more 0.5 to 1, it is green, then yellow, then orange red, and then brick red. If you ever forget this, if you want to remember these things, you can just see that these are actually in the order of Vibgyor. When we quantify light according to their wavelength, the visible light, we call it VIBGYOR, right? VIBGYOR. So it starts with B and it just follows that pattern, GYO and eventually red, which is R. Now in the exam, they ask you some more questions, right? So for example, they ask you what other tests apart from Benedict's test that you can do for glucose. So one thing you could always do is something called as a reagent strip method. As I told you earlier, you can use this anything. For any test, you can say that you can also use something called as a reagent strip method. So now this reagent strip method are this little strips which are present in this bottle, and what you do is you put the strip into the urine and you take it out and then you compare the colors, right? So some colors change and you compare the color here and you try to see if the color changes, and it is also a semi-quantitative test. So depending on the concentration, you have different shades of the color that you can get. But the advantage of this is not only glucose, you can do a lot of things. So as you can see here, there is blood, there is specific gravity, there is ketone bodies. So everything can be done with this reagent strip method. It is very rapid. You just dip it in the urine and remove it, and you can have all the values at your disposal right away. So now you need not know much about reagent strip method, but we'll just add it for the sake of completeness. So let's take Benedict's reagent. You know that the principle of Benedict's reagent is Benedict's test is rather copper sulfate reduction, whereas in reagent strip method, the principle is glucose oxidase peroxidase. Now talking about specificity, Benedict's test is not very specific for glucose, whereas a reagent strip method is very specific for glucose. So if someone asks you, which is the best test for glucose estimation, your answer should be a reagent strip method, because even other reducing sugars are negative in reagent strip method because it is very specific for glucose, whereas when you consider Benedict's test, a lot of other things can also give you a false positive results. So if I just try to summarize whatever we have discussed so far about glycosuria, there are two types of sugars. There are reducing and non-reducing sugars. And reducing sugar, glucose is an example. Non-reducing sugar, sucrose is an example. And also this Benedict's test can be false positives for ascorbic acid, uric acid and salicylates, which can all give you a positive result on Benedict's test. So also reagent strip method, as I told you earlier, in reagent strip method, there is a procedure, there is a principle called as glucose oxidase and peroxidase method. So it's sometimes called as the God pod principle, which is glucose oxidase and peroxidase. And one thing about reagent strip method is that it is specific for glucose and it will not give you positive result for any other things rather than glucose. So now moving on to ketones in urine. So ketones are, if you think about it, there are alternate source of energy and they are result of metabolism of fats. So in your body, whenever body wants energy, the body will obviously use up carbohydrates. For example, initially it uses glucose, and when glucose are running down, the body will use something called as glycogen, which is a stored form of glucose. Now, if the glycogen is also done, the body will try to use fat, and then the body will also use protein later on. So initially it uses carbohydrates, then it uses fat, then it uses proteins, and that is when the proteins are getting used, you get a lot of muscle wasting. So now when fats, right? So why does the body use fat and how does it use fat is when fats are broken down, they produce something called as acetyl-CoA. Acetyl-CoA is the result of breakdown of fats, and this acetyl-CoA, think about this, it can enter the Krebs cycle in the mitochondria and it can produce ATP, and that is the reason why despite of not having glucose, we can still produce energy by the fat because it can give rise to acetyl-CoA, and this acetyl-CoA can be then pushed into the Krebs cycle and we can actually do that. So now this acetyl-CoA in the liver, it is converted to these things called as ketone bodies. Now you might ask why the acetyl-CoA is getting converted to the ketone bodies. The answer is very beautiful to remember, and that is there is something called as the brain, right, which is more important for energy, etc., because it is consuming a lot of energy. Now people whose body is unable to use carbohydrates or who don't have carbohydrates, so what happens is you want to deliver energy, ATP, to the brain as well, right? So without that, the neurons are very quick to die. So you should provide energy as much as possible to the brain. Now the bad thing about acetyl-CoA is the acetyl-CoA cannot enter the brain because of something which we talked earlier, that is the blood-brain barrier. So acetyl-CoA structure, etc., is a little different and it cannot enter the blood-brain barrier. But the ketone bodies can enter the blood-brain barrier. That is the reason why your body has converted some of this acetyl-CoA into the liver and they produce all these ketone bodies so that these ketone bodies can cross the blood-brain barrier and they can supply energy to the brain. And in the brain, the ketone bodies can once again be converted back to acetyl-CoA and they can once again be sent inside the cell to the mitochondria for the Krebs cycle. And that is how the process happens, and that is how the body is able to generate large amounts of ATP despite the absence of carbohydrates. So now there are different types of ketone bodies that we need to know for the exam. So one is called as acetone, one is called as acetoacetic acid, and one more is called as beta hydroxybutyric acid. Now acetoacetic acid is sometimes also known as acetoacetate, whereas beta hydroxybutyric acid is sometimes called as beta hydroxybutyrate. So now, as we talked about earlier, normally we don't see ketones in the urine, but we don't even see ketones in the blood. But despite the special conditions in where we see ketones in the blood, so you can get filtration, obviously, because ketone bodies are smaller molecules, so they are not stopped by the size barrier nor the charge barrier. And when they are filtered, they are obviously not reabsorbed as well, because we don't have any mechanism to stop ketones, because ketones are not normally seen in our body. So during ketosis, which is ketone bodies present in the blood, you will also have ketonuria inevitably, because these ketone bodies in the blood are getting filtered by the kidney, and as a result they are not reabsorbed anyway, so they come into the urine. So ketosis is directly proportional to the ketonuria that we see with ketone bodies. Now, what are the causes of ketone bodies? Once again, as I told you earlier, if the body is not getting carbohydrates, the body will start creating this ketone bodies. So number one, you need to remember is starvation. So obviously when you are starving, in one day all your glycogen etc will run out, and your body will start going to this fat, and this fat will then produce acetyl-CoA, which is then converted to this ketone bodies. Now number two, very importantly, there is an acute complication of diabetes mellitus called as diabetic ketoacidosis. Now think about why this is happening. Before I told you that there is a molecule called as GLUT4, which is a channel which allows the entry of glucose, but without insulin, the glucose is not going into the cell. Now, if the glucose is not going into the cell, it is unable to produce ATP energy. So if it is not producing ATP energy, your body thinks that the carbohydrates are not there, and the body will start using fat. So even though the patient has hyperglycemia, the body will still think that the patient is not having glucose, so the body will think he is not having any carbohydrates, and as a result the body will move towards fat. So what are the causes of ketonuria? There is number one is starvation, and number two, as we already talked about, is diabetic ketoacidosis. Number three is alcoholic ketoacidosis. Once again, alcohol ruins your body's metabolism. It will produce a lot of NADPH, etc. And as a result, there is some alteration which happens in the metabolism. And then even with people with fever and vomiting, because obviously when you're vomiting, you're not consuming a lot of calories. And also when you have fever, your metabolic rate is high. And as a result, a lot of carbs are getting taken off, and especially when you have something vomiting etc, you are not getting enough energy inside in the form of carbohydrates, your body will start using fat. And also there is also a condition called as thyrotoxicosis, which you commonly see with the condition called as Graves' disease, which is a hyperthyroid situation wherein once again the body's metabolic rate is so high that whatever glucose your body is getting used up, and as a result the body will now start using fat. And also very commonly people nowadays are using something called as a keto diet to lose weight, wherein they don't take any carb, they only take fat and protein, and as a result they trick the body into thinking that the body is having starvation, and as a result the body will mobilize and use fat. So that is the keto diet. So this is in a nutshell all the different causes of the ketonuria. Now what are the tests that we use for ketonuria? So one common test is called as the Rotheras test, and this Rotheras test is I'll talk about that just in a while. And as I told you earlier that there are also other tests such as the reagent strip method, and there is also one more test which some old examiners like to ask, and that is the Gerhardt's test. So reagent strip method is not that important in ketonuria because the principle of it is very similar to Rotheras test, but you can still mention that the reagent strip is also another method which can be used for measuring ketone bodies in the urine. But one more thing to remember is Gerhardt's test, as I told you earlier, which I'll talk about just in a while. So we'll talk about Rotheras test. For Rotheras test, you need three things. So initially you need 5 ml of urine. Then you need this crystal looking thing which is called as ammonium sulfate. So you saturate it with ammonium sulfate. So you take urine and you put this ammonium sulfate and you try to saturate it. Then you also see this little brownish crystals. These are called as sodium nitroprusside. And along with that you need liquor ammonia. Liquor ammonia is nothing but it is ammonium hydroxide, which is a very good alkaline material, which is ammonium hydroxide. So let's see how this test is done. So I'm adding a lot of ammonium sulfate crystals. So I'm just saturating it as much as I can. And then now I'm adding a pinch of sodium nitroprusside. So there is nitroprusside in that. And now what I'm doing is I took the dropper, and in the dropper I'm trying to add some liquor ammonia, which is ammonium hydroxide, and I'm trying to add it. Now, very, very important is that when you add this liquor ammonia, see how I'm adding it from the side. It just rolls down the glass and it comes to the side. That is only when you get a good ring. If you don't do that, you don't get a good ring. The whole solution will turn purple, but rather here you can see there is a very nice ring. I'm just waiting for it to focus. So let's add some more things so that the ring is more clear. So once again, I'm adding it from the side. I'm adding this ammonium hydroxide from the side. And now you can see there is a very good ring which is formed. So this ring represents that this Rothera's test is positive and this urine is containing ketone bodies. So now Rothera's test. What is the principle of Rothera's test? So Rothera's test doesn't test for beta hydroxybutyrate. What it tests for is acetoacetic acid. None of the screening tests are testing for beta hydroxybutyrate, so don't worry about that. So acetoacetic acid in presence of nitroprusside will form in the alkaline medium. That is the reason why we added ammonium hydroxide, and they eventually form this purple color. So as I told you earlier, none of the screening tests test for beta hydroxybutyrate, so you do not worry about that. So when your body produces ketone bodies, it doesn't only produce beta hydroxybutyrate, but it produces all the three. So once you confirm the presence of one, that means all the other three are also present. So there are some false positives to remember for Rothera's test as well. That is, even though you don't have ketone bodies, the test can still turn positive. So one good example of this is L-DOPA. You know where L-DOPA is used? L-DOPA is a precursor of dopamine and it is used in a disorder which has less dopamine. So if you're thinking about Parkinson, you're right, because in Parkinson syndrome, what you have is you have degeneration of the dopaminergic neurons in the brain, and as a result, you need dopamine to give to this patient, and that's why you give L-DOPA, because normal dopamine doesn't cross the blood-brain barrier, whereas L-DOPA crosses the blood-brain barrier. So apart from the Rothera's test, there is also one more test I told you. It is called as the Gerhardt's test or Gerhardt's test. So it is using the reagent that has been used in Gerhardt's test is 10% ferric chloride. I like to remember it as the first three letters of Ger. Gerhard is Ger and it is fer, right? So Gerhardt's test, and which uses ferric chloride. And the principle of this test is, once again, it acts on acetoacetic acid, and as a result, it produces reddish or purplish color. So not much there. Both of them produce purple color. Whereas in Rothera's test, we use sodium nitroprusside, which is acting on acetoacetic acid. Whereas in Gerhardt's test, it is using ferric chloride and it is combining with acetoacetic acid. So just to summarize ketonuria, causes of ketone bodies, you think of whenever you don't have enough carbohydrates. So number one is starvation. Number two is diabetic ketoacidosis, because the body is unable to use glucose anymore. Alcohol, fever, vomiting. Then you can also have thyrotoxicosis, and also people who are on keto diet. Then Rothera's test we talked about earlier, that is sodium nitroprusside reacts with that and you get a purple ring. And then also Gerhardt's test. Gerhardt's test is 10% ferric chloride, and that is also acting on acetoacetic acid and producing a reddish or purplish color. And there are some false positives, and one false positive which is important to remember for ketone bodies is L-DOPA, which gives a positive Rothera's test. Now moving on to protein in urine. So when you have proteins in urine, it is called as proteinuria. Now finding protein in urine, is it normal or abnormal? So normally our body excretes about less than 150 mg per 24 hours. And this is not normally detected on routine tests. So if you do any tests, these are not detected. So proteinuria is called when there is greater than 150 mg per 24 hours, and that is where we call it proteinuria. So as I told you earlier that the body normally excretes less than 150 milligrams per 24 hours. Now where is this protein coming from? And most of this protein is actually secreted by the tubules. So the tubules here, they secrete some proteins, the cells, they produce some proteins, and these proteins, there is one such protein, and this protein is called as Tom Horsfall protein. So just keep this in mind. So it's not very important for you to remember that, but I'll just tell you that the tubule normally secretes a protein called as Tom Horsfall protein. And I'll tell you the importance of this Tom Horsfall protein when we talk about hematuria, that is blood in urine. But just remember that in normal people like you and me as well, the tubule normally secretes some protein which adds to the trace amount of proteins which are getting secreted, and when you look at them, they'll look something like this. They're like with this long structures, which are like long and elongated structures which are found when we do urine examination in a normal person, which refers to a Tom Horsfall protein which is secreted by the tubules. So as we talked about earlier, when we consider albumin, albumin is not excreted by the kidney are not filtered by the kidney, at least because of the negative charge of the albumin is getting repelled by the negative charge of the glomerular basement membrane and the epithelium. So albumin is not filtered properly normally because of that charge barrier, whereas there are smaller proteins such as immunoglobulin light chains and some microglobulins. They get filtered similar to glucose, but they're reabsorbed in the proximal convoluted tubule. So when I told you about Fanconi syndrome, I told you that apart from glucose, it cannot also take up some of this amino acids, and these are actually the smaller proteins such as immunoglobulin light chains and small microglobulins which get filtered, but they are reabsorbed by the PCT. So we'll talk about the causes of proteinuria. There are different levels of proteinuria which can happen based on how things are. So number one, obviously, the most of the proteins are stopped from getting filtered by the glomerulus. So if there is any damage to this glomerular filter, you can have proteinuria because the barriers don't work anymore. So the first cause of proteinuria is the glomerular causes. And a very good example of this would be nephrotic syndrome and nephritic syndrome. And number two is the tubule. So previously I told you that there are some proteins which are getting filtered, but they are getting reabsorbed, such as immunoglobulin light chain or smaller microglobulins. But if there's something wrong with the tubule, the body cannot reabsorb these proteins, and these proteins will show up in the urine. And this is why the second cause of proteinuria is tubular causes. So one of the reasons why the tubular epithelium cannot reabsorb these proteins is when you have infection of the tubule, which is called as the kidney infection, which is called as pyelonephritis. So number three, this three is kind of interesting, and this third cause is called as overflow proteinuria. Now, the meaning of overflow is that when there are a lot of proteins which come into the Bowman's capsule, that is called as overflow proteinuria. I'll give you a very good example of this, and the example of this is multiple myeloma. We all study about multiple myeloma and all the years of medicine because it is the pathogenesis of multiple myeloma and the pathology it causes is very interesting. So you know that multiple myeloma is a clonal proliferation of plasma cells. That is, one plasma cell undergoes some mutation and it produces many more plasma cells which are exactly like that. So that is why we call it clonal proliferation, because they are all coming from one subset of this plasma cell. So let's take one plasma cell. Let's imagine that this plasma cell has undergone a neoplastic change. It has become a tumor. Now it is called as multiple myeloma. So it divides, it produces a lot of same clonal plasma cells, right? So what is the function of plasma cells when you think about it, right? Plasma cells produce antibodies. So antibodies, are immunoglobulins which contain a light chain and a heavy chain. So here in multiple myeloma, they produce a lot of light chain, all clonal light chain, whether it's kappa or lambda, etc. So let's forget kappa, lambda, but just focus that there are a lot of light chains which are produced by the plasma cells. So as they produce a lot of this immunoglobulin light chain, all of this immunoglobulin light chain comes into the Bowman's capsule, because remember that there are small particles and these small particles are filtered by the kidney and they are supposed to be reabsorbed by the tubule. So when all of these come into the Bowman's capsule and when they're going to the tubule, only some of them get absorbed by the tubule. Imagine this is very similar to what happens in diabetes mellitus and glucose. In diabetes mellitus, you have more glucose molecules than the transporter proteins. So here as well, you have a lot of proteins because multiple myeloma regenerates, produces, divides and produces a lot of these proteins. And what happens eventually is that only some of they get reabsorbed, whereas the other things, they just fall down and they just come into the urine. And that is where this proteinuria occurs in multiple myeloma. Now you remember what is this proteinuria called as? What are these proteins called as? All these light chains which are coming in the urine. If you are thinking it is Benz-Jones proteinuria, you're absolutely correct. So this question also will be asked in the exam. If you get protein, they'll ask you what is Benz-Jones proteinuria, and you tell them that it is the type of proteinuria which is seen in multiple myeloma, wherein there is a lot of production of immunoglobulin light chain, which is not completely reabsorbed by the tubule because there is so much more number than the transporters. So eventually all this thing will just flow into the urine, and this is called as Benz-Jones proteinuria. And very importantly, remember what is the spike that this Benz-Jones proteinuria causes. When you do an electrophoresis, it will cause something called as an M spike in the urine, and this is very characteristic of multiple myeloma causing Benz-Jones proteinuria. So there is one more cause, that is 4. I have also kept this 4 near the glomerulus because there is one transient cause of proteinuria called as hemodynamic proteinuria. So you know that the glomerulus has two things. It has an efferent arteriole, efferent arteriole. So if some pressure changes in this side and that side, sometimes it can cause more filtration, and as a result, sometimes some people can get some amount of proteinuria. So people following heavy exercise or people with cardiac failure, they can actually have some amount of proteinuria happening due to the hemodynamic changes happening at the glomerulus. So especially with exercise and everything, it is reversible. So that is, once you stop the exercise and once the time passes, the proteinuria will go back to normal and you will not see any proteins in the urine. And lastly, number 5 is post-renal causes, because just remember that urinary tract is not just nephron, it has a lot of other things such as pelvis, ureter, bladder, and when you have infections there, there is also a likely chance that you can get these. So proteinuria here once again can be selective or non-selective. So the reason why I say selective is that there is only one type of protein. For example, let's take albuminuria. When I say the word albuminuria, I'm referring to there is only one type of protein which is coming out, and that is the albumin. So this would be a selective proteinuria. So sometimes the examiners can ask you what is selective and what is non-selective proteinuria. And one of the good examples of selective proteinuria is albuminuria. Think about this, right? So when I show you the filter here, the filter has this negative charge, and that is the reason why it is actually repelling the albumin that we talked about earlier. Now imagine what would happen if this negative charge was somehow removed from the glomerular basement membrane and epithelium. So there is no more negative charge to repel the albumin away, and what happens as a result is that now you have the albumin which is coming into the urine and it is getting filtered. A very good example of this would be diabetic nephropathy, which causes proteinuria. And initially, this proteinuria is microalbuminuria. That is, it is about 330 to 300 mg per 24 hours. For some reason, all the examiners like to ask you about microalbuminuria, and they'll ask you what is microalbuminuria. You tell them that it is 30 to 300 mg for 24 hours. And as you progress, as diabetic nephropathy progresses, this microalbuminuria will only increase in number because there is more damage to the glomerular filter, there is more damage to the charge barrier. So eventually this becomes overt albuminuria, which is greater than 300 mg per 24 hours. So micro is 30 to 300, whereas overt is greater than 300. So now there are a lot of tests that you can do for proteinuria. One of the most common tests that we do is called as heat coagulation test. But apart from that, you also have reagent strip method, even though it is not very important to remember reagent strip method for this proteinuria. And then also there is one more method called as sulfosalicylic acid test. So let's talk about these tests. So now let's start with heat coagulation test. Now you know that heat coagulation test, what we do is we fill the two-thirds of the tube with urine. So two-thirds in the sense, I mean around 67%. We are filling it with the urine, and then we heat only the top portion. I'll just tell you why we only heat the top portion, but we heat the top portion and we see, because once you heat the top portion, that area will form the coagulum. So just in case, once again I'm showing you what happens when I'm heating the top portion. So already I got this coagulum on the top. I don't know what the hell am I doing, but I'm just trying, I think, to put it into focus to show you that the clear difference. Hopefully it's coming soon. Yeah, it did. So I think, yeah. So there we go. So perfect. We have this coagulum which is formed at the top, and it's clear at the bottom. So now, when people say, they'll definitely ask you when you get this heat coagulation test is that why heat only the top portion? Now, the reason why you heat only the top portion is, see, sometimes urine can be turbid and it can be cloudy, etc., depending on the amount of proteins which are present in the urine. Now, we heat only the top portion because this is the part which has changed in color, and we can compare that with the bottom part which acts as a control. Now, instead of using two test tubes, we can get the test and control done in one test tube. That is the reason why we heat the top portion, so that we can compare the top with the bottom, confirming that the top portion has undergone this coagulation change, and that is important to understand. So once again, are there any false positives for heat coagulation test? The answer is yes, there are phosphates, even though the spelling is a little off here. But please remember that this is phosphates, and there is one workaround it. So even when you have phosphates and when you heat it, you will still get this coagulum. But one workaround this is that it can be eliminated by adding few drops of acetic acid and see if the coagulum dissolves. So when you add few drops of acetic acid, the coagulum dissolves in phosphates, but the coagulum stays when you have proteinuria. And also penicillins, if you have large doses of penicillin, penicillins can also cause this kind of coagulation at the top, right? So this coagulum is formed at the top, and that is also a false positive for this heat coagulation test. And also there is an diabetic drug called as tolbutamide, which can also give a false positive. So the principle is very simple. That is, when you heat the protein eventually denatures, and this denaturation of proteins will form that coagulum. So once you heat the protein becomes denatured, and it is not water soluble anymore, kind of. So that is why it gives you this coagulum-like appearance. So apart from heat coagulation test, there's one more test called as sulfosalicylic acid test. It works similarly. That is, when sulfosalicylic acid is added to the urine, obviously, once again, you add acid to the urine, the proteins will denature and the proteins will precipitate. So that is the principle of sulfosalicylic acid test. So finally, to summarize proteinuria, there are different causes of proteinuria as we talked about. One is the glomerular causes, wherein there is damage to the glomerular basement membrane and to the charge barriers, to the epithelium. So all those things will cause proteinuria. A very good example of this would be both nephrotic syndrome and nephritic syndrome, where proteinuria is seen in both, where there is damage to the glomerular basement membrane. And also there are a lot of other causes as well, such as tubular, and you also have causes such as overflow, and there are also causes called as hemodynamic, wherein there are some changes in the pressure between the efferent and deferent arterioles. And eventually you also have postrenal, wherein you have things like pelvis, etc., where there can be infections, and these infections can lead to some kind of immunoglobulins coming there, antibodies, etc., which can cause a positive protein in urine test. So apart from that, we also need to know what are selective versus non-selective proteinuria. So in selective proteinuria, if you only have albumin coming in the urine, that would be a selective proteinuria. A very good example of this would be the first stages of diabetic nephropathy, which eventually starts as microalbuminuria, which is 30 to 300, whereas eventually it becomes overt albuminuria, which is greater than 300, and eventually it becomes even more severe non-selective proteinuria. And one test that we use very commonly is the heat coagulation test, and we heat only the top portion because the bottom portion acts as a control. So to finish this discussion, we have the last thing here, which is the blood in urine. So when you have blood in urine, I'm referring more to the RBCs in urine. So previously we talked about RBCs are not usually filtered because of their size, but if you see RBC in urine, we are calling it hematuria. So as we discussed earlier, once again, the RBC are very big for the size barrier to get filtered. But if there is some damage to this size barrier, now you can start seeing RBC in the urine because these RBCs are getting filtered at the glomerulus. Now, what are the causes of hematuria? Once again, so as we talked about earlier again, the first cause would obviously be some damage to the glomerulus. So there can be glomerular causes. And a very good example of this, now think about this. There are two syndromes, right? So there is nephrotic syndrome and there is nephritic syndrome. So which causes hematuria? Nephrotic syndrome only causes proteinuria, whereas nephritic syndrome will cause both proteinuria and hematuria. So the answer would be nephritic syndrome. There are a lot of other causes which I'll just talk about later, but one cause to remember in glomerular causes is nephritic syndrome. But apart from glomerular causes, there are also non-glomerular causes because the urinary tract itself is big. For example, you have kidney, ureter, you have bladder, urethra, etc. So there are non-glomerular causes as well, which happens at the renal, pelvis, ureter, bladder, and urethra. So let's say someone has kidney stones or pelvis stones or ureter stones, etc., or they have tumors in the bladder, tumors in the urethra, or any injury to the urethra, any infection, everything will cause some kind of RBCs in the urine, and that is called as non-glomerular hematuria. Now, people would like to ask, what are glomerular versus non-glomerular hematuria? How can you separate glomerular versus non-glomerular hematuria? So remember what I told when we were talking about proteins. I told you that there was a little protein which is secreted by the tubule, which is called as Tom Horsford protein. Now, this becomes important because there is a way we can distinguish glomerular versus non-glomerular hematuria. We'll see how. So this is once again a little diagram which I drew about the nephron, even though it looks very bad. But let's forget about my artistic skills and let's focus on the task at hand. Now let's see that the tubular epithelium, I told you it produces produces proteins which are called as the Tom Horsford protein. And in this case, let's say this patient is having hematuria. So as the protein is going on, these RBCs also come into the tubule and they start getting stuck in the tubule. And as they move towards the tubule, they actually get attached to the Tom Horsford protein which was produced earlier. So all this RBCs, they kind of stick to the Tom Horsfall protein because they are traversing through all this tight places within the tubule, and as a result they all stick to this Tom Horsfall protein. And when you see them, they look something like this, wherein this is the Tom Horsfall protein and they all start binding to it. So as you see, there is a many hundreds of cells, hundreds of RBC which are stuck to this Tom Horsfall protein, and this is called an RBC cast. So we use the word cast because when RBCs are going into this tubule, they take up the shape of the tubule, right? Even the Tom Horsfall protein has this shape because it is going through this tubule. It has this tubular shape, and the RBCs are also sticking to this tubule, and that is why it is called as an RBC cast. And not only RBC cast, since they are actually going into this little spaces and then trying to squeeze their way through, some of the RBCs and their shapes alter. So see this RBC, they all have this little blebbing coming out of it, and these type of RBCs are called as dysmorphic RBCs because they are passing through these tight places, and that's why some of them can get damaged, and these are called as dysmorphic RBC. So you have dysmorphic RBC and you have RBC cast, and you see only them in you don't see them in non-glomerular causes, you only see them in glomerular causes. So that is one thing that you need to remember. So now talking about the test for hematuria, the test that we use for hematuria is called as the benzidine test. And there's also one more test which is very similar to benzidine test. It is called as an orthotoridine test. And there is also, of course, the reagent strip method that is being done. So we'll talk about the benzidine test first. So in benzidine test, you need three things. So one is the benzidine powder. So benzidine reagent. So what we do is we take 1 ml of benzidine solution, that is we add acetic acid and we add some benzidine powder to it. So you take 1 ml of acetic acid and add some benzidine powder to it. So that makes benzidine solution. And then you add 1 ml of H2O2. So one way I like to always remember this is, so 1 ml of benzidine solution, so that is 1, and 1 ml of H2O2, that is 2. So 1 plus 1 is 2. And to this 2, you add 2 ml of urine. So 1 ml of benzidine solution, 1 ml of H2O2, and 2 ml of urine. You can add it in any fashion you want. You can add urine first, then you can add these things first, whatever order, and the solution turns blue if it is positive. So I'll show you what I did. So this is me performing the benzidine test. So I've taken the urine and also acetic acid first. Now I'm adding the benzidine powder. And then I'm giving it a nice shake so that everything mixes well. So I'm done with the urine and the benzidine solution. Now I'm adding 1 ml of hydrogen peroxide. And the moment I add this hydrogen peroxide, you see that the solution has turned into this very nice sky blue. So this blue, once again, suggests that the benzidine test is positive, meaning that there is blood in the urine and this is positive. This is hematuria. Now moving on once again, what is the principle of benzidine test is that benzidine test acts because there are hemoglobin molecules present on the RBC. You know that RBC is made up of hemoglobin. So this hemoglobin will have some kind of a peroxidase like activity. So what is the meaning of peroxidase? Peroxidases are enzymes which break down peroxide. So one thing which we had in the test was we had H2O2, which is hydrogen peroxide. So this hemoglobin breaks down this H2O2. So when peroxidases break down peroxide, so what do you get? You get water and something called as a nascent oxygen, which is a very active form of oxygen. Now what happens eventually is when this oxygen that we have will go and now start reacting with the benzidine solution, with the benzidine powder, and this oxygen and benzidine combination is termed oxybenzidine, which changes from brown to blue. And this blue color thing is called as oxybenzidine, and that is the one which gives the blue color to the solution. Another question examiners would love to ask is, what is the difference between hematuria versus hemoglobinuria? Now hematuria, you know that there are RBCs in the urine, whereas hemoglobinuria is slightly different, and we'll see just now how it is different. Now there are some conditions which can cause intravascular hemolysis. Now think about sickle cell anemia. Some of the sickle cells, they are killed by the spleen, whereas some of the sickle cells are actually, they die within the intravascular space. That is why it is called as intravascular hemolysis. Now also an example of this would be, let's take malaria, because malarial parasites causes damage to the RBC. So some of the RBC can get damaged within the blood vessel, and this is called as intravascular hemolysis. So let's see what happens in intravascular hemolysis. So once again, let's take a blood vessel and let's put an RBC inside. So when you have intravascular hemolysis, obviously the RBCs are damaged and they release a lot of hemoglobin outside. So some of this hemoglobin will find its way into the glomerulus, and because hemoglobin is very small when compared to the RBC, it is easily passed by the size barrier, and they eventually pass into the tubule and eventually they'll come out into the urine, and this is called as hemoglobinuria. Now I'll ask you a question. Is benzene test positive in hemoglobinuria? Think about this. The answer is yes. But the idea is, I told you, when you remember the principle of benzene test, the reason why RBCs give a positive benzene test is because of hemoglobin, and because hemoglobin has this peroxidase like activity. So that breaks up this hydrogen peroxide into H2O and nascent oxygen. So here in hemoglobinuria as well, because there are hemoglobin, they can still break down this hydrogen peroxide, giving rise to a nascent oxygen, which eventually gives rise to a positive benzene test. Now they'll ask you, how will you differentiate between hematuria and hemoglobinuria? Because both of them will give you a positive benzene test. So one difference between hematuria and hemoglobinuria is, in hematuria, you actually have RBCs in the urine. Now you know how you can see RBCs in the urine? By doing a urine microscopy, because once you do microscopy in hematuria, you will see RBC. They can be normal RBC if there are non-glomerular causes, but you can see RBC casts if they are glomerular causes. Whereas in hemoglobin, hemoglobin molecules are very small, so you can't see individual hemoglobin molecules. Whereas in hematuria, you can see RBCs, whereas RBCs are not seen in hemoglobinuria. That is what you answer. You say urine microscopy, I see RBC in hematuria, I don't see RBC in hemoglobinuria. So now there is one more thing which is closely related to HB, which can also give rise to a positive benzene test, and this protein, are you guessing something? So the protein is actually, it is also a globin. It is called as myoglobin, which can also give a positive benzene test. So there are some conditions in which myoglobin is normally present in the muscle. So when there is a lot of damage to the muscle, this myoglobin can come out into the blood, and this can come into the urine. And when you do a benzene test, this myoglobin can give rise to a positive benzene test. So you can sometimes call myoglobin as a false positive test for benzene test. So can you name any conditions in which there is a lot of myoglobin which comes? So one of the good examples would be a crush injury, because when you have a crush injury, a lot of muscles are damaged, and all these damaged muscles release a lot of myoglobin, and they all come into the bloodstream. And you can also add one more example, which is, other causes of rhabdomyolysis, which is once again breakdown of the skeletal muscle, which leads to a lot of myoglobin finding its way into the bloodstream from the muscle and eventually reaching the urine. So just to summarize hematuria again, we have glomerular and non-glomerular causes of hematuria. So there is also hematuria versus hemoglobinuria. So both of these, just we'll go through that again. So how can you differentiate between glomerular and non-glomerular causes? Is that in glomerular causes you see RBC cast, whereas in non-glomerular causes you don't see RBC cast or dysmorphic RBC. Whereas hematuria versus hemoglobinuria, how will you separate? You separate them by doing microscopic examination. In hematuria you will see RBC, whereas hemoglobinuria you will not see RBC. And then you have two types of test. One is benzene test and orthorolidine test. Orthorolidine test is very similar to benzene test. Instead of benzene, we just put orthotolidine, so which binds the oxygen and changes color. So that would end all the discussions that we had about all the things. So I'll just discuss some of the test questions that we have in our college. So number one is a 55-year-old male patient with history of polydipsia, polyphagia, and polyuria. So based on this, you should already say that the diagnosis is diabetes mellitus. So we'll see once again, it is admitted in an unconscious state and the BP is down. And then while investigations, we see that the blood sugar is 400 mg per dl, but the serum creatinine is normal. So the diagnosis of this would be diabetes mellitus. And since it is the patient is actually not very well, he's in unconscious state and BP is 80/60, you are thinking of an acute complication of diabetes mellitus, which is actually diabetic ketoacidosis. Now, how would you confirm diabetic ketoacidosis? Is you initially do the test for the ketone bodies and everything. So what we do is, in the exam, when we get this, we write it like that. So once you write in the exam, you don't need to write the procedure. You only need to write the test, the observation, and the inference. You need not write about the principle as well. So when the examiner asks you, tell them, but in your paper, in your exam paper, you should write just these things. That is, you put a box and you write what is the test that you have done. So in the first thing, you have done the Benedict's test, and this Benedict's test you see brick red precipitate, and your inference is that reducing sugars, that is glucose, is present in the urine. And then you do Rothera's test, and in the Rothera's test, if ketone bodies are there, you'll get a purple ring, and that means ketone bodies are present, and that is your inference. So once you get this inference, you can write a report saying that the urine is positive for glucose and ketones. So based on the clinical question, the diagnosis now would be diabetic ketoacidosis. Now, why does it is called as ketoacidosis? So think about this, because when I told you about ketone bodies, I told you there are three types of ketone bodies. There is acetone, there is acetoacetate, and beta hydroxybutyrate or beta hydroxybutyric acid. Acetoacetate is also called as acetoacetic acid. So all these acids, when they accumulate, they cause ketoacidosis, and the pH of the blood gets low, and it is very dangerous to the patient because pH, even the slight variation, sometimes can cause dysfunction of the bodily proteins, that's why it's very important to treat diabetic ketoacidosis. Moving on to question 2, you have a 60-year-old male who presents with generalized edema of 1 month, and he's a known diabetic, so we are telling you something about diabetes, and on examination there was generalized edema. Now we also know that the blood sugar is 250, so despite of this guy using anti-diabetic drugs, the blood sugar is not controlled, and creatinine is 1.8, which is elevated. So you have a diabetic patient who has some problem with the creatinine, that is kidneys are not exactly doing their job. So what is the diagnosis of this? So what is the kidney complication which comes with long-standing, not well-treated diabetes mellitus? The answer is diabetic nephropathy. So the diagnosis to that question is diabetic nephropathy. And you know why there is edema in diabetic nephropathy? Let me explain why. So in diabetic nephropathy, previously also when we were talking about proteinuria, we talked that in diabetic nephropathy there is albuminuria. So there is a lot of albumin. Initially it starts less, but as the disease progresses, more and more albumin will actually go outside in the form of urine. And then because you're losing a lot of albumin, what happens to the albumin levels in the blood? So they decrease, and that is why it is called as hypoalbuminemia, meaning that there is less albumin in the blood. Now, I'll tell you what happens if there is less albumin in the blood, but before that, let's understand that let me take a water bottle, and what happens if I put a hole here in the water bottle? When I put a hole in this water bottle, you know that the water will start leaking outside. So why are the water leaking outside? Why they are not going inside, but why are they not staying inside? The reason why is there is a pressure which is exerted by fluids from inside to outside all the time. So if I take this example of a blood vessel, inside the blood vessel also there is a fluid which is the blood, and this blood is always generating a force to the outside, and this pressure is called as the hydrostatic pressure. But our blood stays inside the blood vessels, it is not really leaking outside. The reason for that is there is also another pressure or other force which is acting inside of the cell, and this pressure is called as the oncotic pressure. And can you see all these yellow things? So this oncotic pressure is actually mediated by plasma proteins and especially albumin. So in people like, for example, in people like diabetic nephropathy, the number of albumin molecules have decreased. So as a result, what happens? The oncotic pressure will decrease, and as a result, the hydrostatic pressure will now dominate the oncotic pressure, which has gotten smaller because of the loss of albumin, and eventually a lot of this plasma will flow outside. And what happens when you have more fluid in the interstitial area? That is nothing but edema. So that is the reason why these people get edema. So diabetic nephropathy, so as I told you earlier, there are two types of syndromes, nephrotic syndrome and nephritic syndrome. So tell me, what syndrome does diabetic nephropathy fall under? So diabetic nephropathy, because there is no hematuria, there is only proteinuria. So severe diabetic nephropathy, wherein there are more than 3.5 grams for 24 hours. That is how much sometimes in severe cases of diabetic nephropathy is the amount of protein which is getting excreted. At this point, we call it nephrotic syndrome. So for calling nephrotic syndrome, you need at least greater than 3.5 grams per 24 hours. So the way I like to remember this thing is, in nephrotic syndrome, you have an O, whereas in nephritic syndrome, there is an I. So in O, there is only proteinuria, whereas in I, there is both proteinuria and hematuria. So O for only proteinuria. There can be other things such as fats can become in the urine, etc., such as fat bodies. But when comparison with protein and RBC, remember that only proteinuria is seen in nephrotic syndrome, whereas in nephritic syndrome, both proteinuria and hematuria is seen. So when we write in the exam, we write it as Benedict's test is obviously positive, brick red, so glucose is present. Then we also write heat coagulation test, coagulum is formed and protein is present. So our report would be urine is positive for both glucose and protein. And as a result, my diagnosis based on the question as well would be diabetic nephropathy. So now, since we are talking about nephrotic syndrome, let's talk about a concept called as 24-hour urine sample, because I told you that for you to call it nephrotic syndrome, the protein excretion should be greater than 3.5 grams per 24 hours. So the way we collect this 24-hour urine sample is we ask the patient to void the first day sample. That is, we don't collect the sample, the early morning sample, the first sample which comes after the patient wakes up, and then we start collecting and we collect it until the next day. And what we do is we pour it in a jug, etc., and we eventually get this to some few machines called as few little instruments called as SPAX albinometer. For example, we also have this SPAX albinometer in our college. So what we do is we add that, we concentrate, we see how much concentration of protein is there, and when we add the whole volume, we get how much exactly the amount of protein which is getting excreted. So that is 24-hour urine sample, wherein we void the first and then we start collecting for a period of 24 hours. So lastly, we have this question once again, and this question is: a 7-year-old male presents to primary care physician with the chief complaint of cola colored urine. So once again, when you see cola colored urine, you're thinking of hematuria, facial puffiness, meaning facial edema. So now you have to think of hematuria and also proteinuria. And they're also saying that 14 days ago, he had a sore throat and fever. So the answer is right here. So is it nephrotic syndrome or nephritic syndrome? So obviously it is not nephrotic syndrome because this patient also has hematuria. So it has to be nephritic syndrome, and it is nephritic syndrome. And this nephritic syndrome is called as post-streptococcal glomerulonephritis, wherein a lot of immune complexes will start depositing in the glomerulus and damage. But this is actually very transient. The patient will get back to completely normal in a few days, and the treatment is only supportive for this patient. So here as well, when you write the urinary findings, so how will you write? So when we write it as benzene test initially, and it is blue color, and that means that blood is present. Whereas the heat coagulation test, coagulum is formed again, and it is protein is present. So both proteins and RBC are present. So that will be my report, that is blood and protein are present. And what is my diagnosis? It is nephritic syndrome. And based on the history, the patient had sore throat and fever 42 weeks back, and this is called as post-streptococcal glomerulonephritis, which is an example of nephritic syndrome. And this nephritic syndrome is proteinuria and hematuria, as we saw in this case, which is hematuria due to cola colored urine and proteinuria that is leading to facial puffiness, etc. So that will be the end of urine examination. So if you have made it this far, pat yourself on the back, and hopefully you have taken few points out of this, and I wish you all the best for the exams to come, and hopefully you can get as many marks as possible in urine examination.